So this is the topic: addiction recovery and peer support. Um, so yeah, for those who don't know me, I've been on the clinical faculty since 1985 when I was teaching in the family medicine residency in Eau Claire when I was practicing up there, and full professor now and still doing the volunteer work. And I met a number of you when I was working as core faculty. And as I love to say, I'm in a gig where they're now paying me to do what I've volunteered to do for the last 33 years. And now it was those 2 years plus another couple that gets us to today. So, actually, it's been 1 year since I retired from that role. I also am a clinical faculty of my PGY 1 and 2 alma mater, MCW Department of Psychiatry. And I provide mentorship for their program director, who was a fellow there, and I worked with in her fellowship. It's probably been a decade or more ago. But also provide didactics for the fellows there. And then I volunteer with other places. Today I did a presentation for Howard University because I know the fellowship director, and yesterday for Tulane, my medical school alma mater. So I'm no longer interim medical director of Connections. I retired from that one 3 weeks ago, but I still have my fellowship status in the two professional societies. And there we go. None of the disclosures make a hill of beans for today's presentation because it's on peer support groups, but I do consult now to health systems like AMITA and actually the clinic down at Carl in Champaign-Urbana, to drug testing labs like Ammon, to pharmaceutical companies like Alkermes, to Orexo, not for its Zubsolv product, but for some medical devices to develop online tools for treating depression, to the government to SAMHSA grantees through JBS, and professional societies and others. So this is my life now. I'm down to 6 patients, and those will fade out in the next few months. And but I do other stuff, including expert witness work. So again, we're going to kind of get into some policy. Yes, Randy said I've been involved with policy and writing these policies and being chair of the Public Policy Committee at ASAM for a number of years, et cetera. So if our topic is using peer support to facilitate recovery, we got to decide what's recovery. And the definition that we developed in 2013 through what we called the Descriptive and Diagnostic Terminology Action Group at ASAM, DTTAG, we had definitions for abstinence, for recovery, et cetera. And the bottom line is that we believe that people on medications for opioid use disorder, even the agonists and partial agonists, are still in recovery and abstinent because they're part of recovery. But recovery is not a destination or static, it is a process. And it has to involve not dinking around or dabbling, but sustained action. And you want to address all aspects inherent in addiction: the biological, the psychological, the social, and the spiritual. You want to improve quality of life and pursue wellness. And those of you that have worked with me clinically, like I saw Cindy up here, know that when I work with patients, I do talk about personal responsibility. And part of that is, what are you doing for your general health status? Do you have a doctor? And most doctors in recovery don't, in early recovery, when they come into treatment. Do you have a primary care doc? Are your pap smears up to date? Are your immunizations up to date? And even in this day and age, are your immunizations up to date? What are you doing to be responsible for your personal health and wellness? And we want to see about quality of life, because indeed another project which I did not put a slide up for, and it's actually a little bit hard to find, but go ahead and look it up. It's relevant to what we're talking about today. It was the recovery language project of Faces and Voices of Recovery, which has a very interesting website. Every word is spelled out in full with no dots and spaces. Faces and Voices of Recovery.org. And you want to look for the recovery messaging. And they got some academics, people in community surveys and social marketing and whatever, and they tried out different messages. to try to see what's most likely to get somebody who's not in recovery to get into recovery. And they found that addiction as a brain disease doesn't ring bells, interestingly. The one that rings bells is this. I am a person in long-term recovery. For me, that means I have not used drugs or alcohol since blank date. That has allowed me to become functional in my family and in my community. So you have a reduction or elimination of symptoms, and you have maximization of functional status. And functionality has to be a goal in quality of life as a measure of functioning. So we built into the definition of recovery some terms from the ASAM definition of addiction, where we talked about impairment in behavioral control, cravings, diminished recognition of one's of the problems in your behaviors and your relationships, and a negative emotional response. So we talked about those in the definition of addiction. So we came to the definition of recovery. We said we want somebody to be working on those, and it's you're working on it. You're working on all this stuff. Now, it begs the question of, can anybody say they're working on it and never really make progress? You know, does it become a cop-out to say I'm working on it rather than I've got some success here? And that's something that's probably dealt with by a sponsor or in therapy. You keep saying you're working on it. Really? Like you know, show me, give me something. So at any rate, it is a process. Now, the Betty Ford Institute, which is the nonprofit arm of now the merged entity called the Hazelden Betty Ford Institute, but I'm sorry, the Hazelden Betty Ford Foundation. The Institute is their nonprofit entity, and they got a consensus panel together, including Tom McClellan and the late Garrett O'Connor, who was the medical director of the professionals program at Betty Ford at that time, and others. And their consensus work was published in the journal that Tom McClellan edited back in 2007, JSAT, and you can find it. So what is recovery? And they said recovery is, oh no, I'm sorry. I don't have that slide, I don't think, but they have their own definition of recovery. Now, again, I talked about abstinence, intentional restraint from what the ASAM definition, long version, calls pathological pursuit of reward and or relief that can involve the use of substances and other behaviors. So again, this is right out of the definition of addiction. And we said you're holding back from the pathological pursuit. And it's not that you've been forced by incarceration or some other external pressure. You are putting in the effort. That's what it means. Now, if eating or exercise are your unhealthy rewards, it doesn't mean you're abstaining from all exercise and abstaining from all eating. That's absurd. But it's a non-pathological pursuit. It's using them as healthy rewards can be okay. But we're not going to say that you can use alcohol or gambling as a healthy reward, because those aren't natural rewards or things needed for life sustenance. But physical movement, physical activity, eating, drinking are required. So for the behaviors that are involved with addiction, if you have to engage in them, you do it in a non-pathological way. If they're not required for human functioning, it's total abstinence from gambling, total abstinence from drinking and drugging. Okay, so again, the forced period of non-use does not constitute abstinence. So you can be in recovery while taking an agonist or partial agonist in the context of medically managed treatment. This is the punchline we wanted to get to. So stop saying that people that are on MOUD are getting second-class treatment or have second-class results, because that's just not useful. Okay, a general framework is the second big bullet. So let me get to the first big bullet first. The reason that we recommend abstinence, the reason I recommend abstinence to patients. Now, again, that's for treating addiction. That's not for treating unhealthy substance use. It's not for treating what the DSM-5 calls SUD mild. I'm talking about addiction, which is roughly equivalent, but not completely equivalent, to DSM-4 SUD moderate and severe, or addiction that ASAM describes. I recommend abstinence. And then people say, is it because you've been brainwashed? Is it because you have bought into the religion of AA? Do you have a bias that has you on this bandwagon? No, thank you. AA is not a religion. And the reason that I recommend this is it's the only reasonable recommendation I can give to someone who has the brain disease that involves unpredictable occurrences of loss of control. One of the great studies in this field, that if you're not familiar with it, you should be, is the work done by George Valent, now deceased, put into a rather thick book called The Natural History of Alcoholism. But the basic project was begun in 1948. Valent picked it up when he was a resident and did it for the rest of his life until cognitive impairment kept him from doing it. But for decades, he was the PI on this project. 450 about Harvard freshmen, all men, of course, in that era. Well, that's what there were women at Harvard, I think, in 1948, but no, they probably went to Wellesley. But at any rate, now again, bright, headed to probably professional lives and with means. That obviously some blue collar folks, but mostly silk stocking crowd. In 1948, especially, there wasn't much diversity back then. So let's take Harvard freshmen and then compare them to an equal number, let's call it 450, maybe 475, I don't remember, of building trades workers in Boston, 18 years old. So these are the guys on the blue collar path, all male and assessed on a million dimensions, including, do you meet criteria for alcoholism today, 1948? And what definition they used, I don't know, because that was before the NCA definition of 1972. I don't know whose definition they were using in 1948, but at any rate, if you're not alcoholic at entry to the study at age 18, when do you develop alcoholism? What number, what percentage, and at what age? And that found that the blue collar folks and the white collar folks both develop addiction at the same rates, but the Harvard grads, eventual grads, there's a 10-year delay because assets prop up the individual and allow them to finesse their addiction and not have conspicuous loss of control. And if they do, they can quickly patch things back together and say, oh, that didn't really happen, or whatever, because they're enabled. All sorts of things happen. They get the same disease and they die at the same rates, but as a 10-year delay. Very interesting study. But the other thing that it said was loss of control. Is it possible for anybody who has alcoholism to return to controlled drinking? The answer is that it's not zero. The honest answer is that the Valent study says it's 11%. Why do I recommend abstinence? Because I cannot in good faith recommend something other than abstinence. Because dabbling leads to loss of control. So I tell my patients, why would I recommend you play Russian roulette with a pistol that has 9, I just drew a blank. I guess cylinders, 9 cylinders in the barrel, and 8 of them have live ammunition and only 1 is blank. Why would you do that? So I recommend abstinence because recommending dabbling or controlled drinking has horrible results. So that's why I recommend it. And again, as long as you're working at it, if you've had a slip, you're not crucified. And the part of recovery is getting back on the horse. Don't beat yourself up for having fallen off. So there we go. That's what I do in my professional treatment and my therapy with patients. But here's my little rubric. Treatment includes psychosocial rehabilitation. That's various forms of counseling, various intensities of counseling and psychotherapy, talk therapy, whatever you want to call it. Psychosocial rehab, pharmacotherapy, and then recovery supports. And so we're going to focus on recovery supports. I'm going to jump over, for the purposes of time, the slides I put in here on what is addiction treatment. This wonderful policy statement, last revised in 2010 with Ken Roy from Tulane being the lead on that. A fabulous statement that, for the life of me, I can't figure out why the ASAM board is so trigger happy to to put policy statements in the archives in mothballs. It's as valid today as it was then, and they don't have a new one as a substitute, and so our website has no active policy on treatment, which just blows my mind. But I'm not part of governance anymore. That was decades ago. But this is what this policy statement on what professional treatment is. It's planned, it's not haphazard. It's intentional, it's not by whim. It's planned and intentional. And it's delivered by, as you'll see in the next slide, by trained and certified professionals. We want to work, our targets are the health and behavior and personal life and family life of a person who has this disease. So all of those things are targets. Personal and family functioning, responsible behavior, and promotion of your own health. It's designed to enable individuals to achieve and maintain sobriety, physical, spiritual, and mental health, and maximum functional ability. We never lose track of functional ability. Okay. Treatment services delivered, again, not haphazard, but intentionally by professionals. That makes it professional treatment. Okay, again, professionals can offer pharmacotherapy or psychosocial interventions, and then there's the other stuff. So the other stuff is AA, NA, or any of the other things that have been modeled after AA, such as Cocaine Anonymous, Heroin Anonymous, and then Gamblers Anonymous, Overeaters Anonymous, Workaholics Anonymous, any of a number of things related to addictive behaviors, which are manifested, again, by craving, periods of abstinence, but then a return to use despite adverse consequences, unpredictable loss of control, diminished recognition of the extent of your problems, all of that stuff. Okay. Smart recovery is an alternative to AA. It has no spiritual component. It describes, it's a cognitive program, and one of the co-founders is here in Madison. Henry Weinberger, psychologist, now retired, was one of the founders of the model. The thing different about the smart recovery model, besides the fact that it's cognitive only, is that it's facilitated by a professional who in that role is not acting as a professional. There's no charts, there's no charging. It's not medical care. It is peer support, but there is a facilitator who has some professional training, which you do not see in AA. And if there are people in AA who have professional training, they need to leave that training at the door and not act like a therapist or in the AA group. And then working with a recovery coach is a newer example of peer support. So you got 12-step programs, AA since 1935, NA since 1959 or 60, smart recovery since maybe the 80s, maybe the 90s, and recovery coaching, that concept is a newer one. The definition for that you're going to see in just a second. Now, when I built this slideshow, I looked at different things. Does adding pharmacotherapy to psychosocial help? Does adding psychosocial to pharmacotherapy help? Does adding peer support to treatment as usual help? And I went through various permutations, which we're going to jump over real quickly so we can have time to really talk about recovery supports and TSF. This article says that individual therapy can be helpful, and it's effective in improving outcomes, in increasing retention, and in reducing psychiatric symptoms when people have psychiatric comorbidities. But the interesting thing, and you'll certainly hear Randy and others talk about this, is that there's a whole new body of literature now that says that you don't have to want medications for opioid use disorder for them to work. Sort of like you don't need to want isoniazid to work to treat your tuberculosis. If you take it, it'll work. And there are all sorts of papers showing that medications for addiction treatment, specifically MOUD, without adding psychosocial helps tremendously. And so in the buprenorphine studies, they're showing no difference. I haven't seen that in methadone studies, though. The methadone studies over many, many years, methadone's been around since almost 50 years now. It'll hit its birthday just next year when it got legal. There are tons of studies, and many done by Tom McClellan himself, that showed that Adding psychosocial interventions makes methadone treatment outcomes much better, it makes retention better. There's no study I know of that says methadone without psychosocial gets the same results as methadone with psychosocial. But there are articles showing buprenorphine without psychosocial is helpful. My concern is about long-term outcomes, and most studies are only 12-week studies. And what happens when you stop the med? And of course, some people can be on it for life, but my approach to this is if you don't get psychosocial interventions or engage in recovery activities such as peer groups or working with a recovery coach, if you don't do any of those, when you stop meds, whether it's at 6 months, 9 months, 12 months, or 24 months, your chance of relapse is extremely high. That's just what my experience has been. So again, if you did a study for 24, 36 months, which are too expensive to do, I think that would be borne out. So here is another, most individuals don't receive any treatment. That's the truth. And that's not because the treatment's not available or it's too expensive, they don't have insurance, it's because they don't believe they need it. So the treatment gap that a lot of people say, look at this treatment gap, you know, only 5 or 10 or 20% of people get treatment. Our treatment system needs to be expanded. No, yes, it does, but the real problem is people don't believe they have a condition, or if they believe they have a condition, they believe they can handle it themselves, and they don't seek treatment because they see no need for it. And that's the problem on a population basis. So a lot of people, most people don't get it. Among those who do, many receive only inpatient care. That's not necessarily the truth anymore. Actually, this article was from 2020, interestingly. But it is a key that many people who get residential care do not get outpatient follow-up or medication, which is really tragic. So a little bit of statistics here. So another article that you could look at. They did say there's scarce prior research. Shelley was a somewhat recent, last decade, president of American Academy of Addiction Psychiatry. Okay, let me just jump over because, yeah, this again says there's evidence that adding the results now, what's the date of this? 93. This may have been a methadone study because, again, buprenorphine wasn't even out yet. So there you go. There you go. So there are articles that talk about the benefits. Mark Gallanter is a great, the chair of the ASAM 12-step recovery interest group and a longtime fellowship director at NYU, though he's retired from that role. But at any rate, and they looked at this stuff and they found that a more intensive recovery orientation led to better outcomes. Okay, so is professional treatment the only path to recovery? I don't know the number or the percentage. Somebody may know, but the percent of physicians in recovery who've never been to professional treatment at all for addiction, they've just gotten well through AA. They haven't. I mean, some people stop on their own, which is very unusual for it to be effective. But a lot of docs, one of my former partners here in Madison, was in recovery for many years and did it through AA alone. So I'm not going to say you have to go to professional treatment, but as the ASAM definition says, if it's available, you should go. And it does certainly give you the best chance of a good outcome. So again, what are the treatment components? Again, talk therapies, medication therapies, and recovery supports. So what are the peer support activities? Again, it's called self-help, but it's not DIY. It is working with others, interacting with peers. It's peer support groups, again, of various stripes. I talked about a number of these. Others are, there's a Christian-based that's called Celebrate Recovery, and CR groups, interestingly, are for the individual addiction and affected family members, whereas in traditional AA and NA, people go to Al-Anon or Nar-Anon if they're an affected family member or loved one. But in CR, the people with addiction and the family members go to the same group, and it does have a Christian bent. It's explicitly religious, not just spiritual. And then there's Alcoholics Victorious, which is even more sort of conservative, fundamentalist Christian. So there's a whole variety of groups, and of course we did mention SMART. And I love SMART recovery, and I love when people go to SMART recovery and people say, I've tried AA, I think I want to try SMART, I've tried SMART and I like it better. I say, fantastic. But I will tell you that SMART recovery has not been victorious in the marketplace of ideas. In communities where there's AA and there's SMART recovery, there's just a whole lot more AA. SMART recovery is not as ubiquitous. It's been around for decades now, and it just hasn't caught on. It's there, it's helpful, but I think the best way to phrase it is it hasn't won in the marketplace of ideas. More people find AA helpful, and AA meetings are more available. And the only criterion for going to AA is, quote, a desire to stop drinking, unquote, which would translate into NA, a desire to stop using drugs. You don't have to abstain to go to AA. You just have to have a desire to stop, and that you're working on it. And AA is welcoming. It doesn't kick people out. Sometimes they'll escort out a person that's unruly, but if somebody comes in, a quarter in the bag, and they're obviously slurring their speech a bit, which can be triggering for others, but they really seem sincere, they let them sit there in the meeting, and then after the meeting, somebody will go up to them and put their arm around them and really work on them and help them get a detox if necessary, etc. But they don't make a scene and kick them out of the group. In professional groups, when somebody shows up under influence, it is important to say, this group needs to be a safe and sober place, and if you show up under the influence, that's not cool. Okay, now, is peer support treatment? Well, this was addressed by a joint group of ASAM, the American Academy of Addiction Psychiatry, AAAP, and the APA way back in '97, almost 25 years ago. And one of the motivators for this policy statement was that at that point in time, managed care, you would submit a request for treatments before parity. And a lot of people had no benefits at all. Others had very limited benefits. So you'd say, I want to get prior authorization for psychosocial treatment after either IOP or residential. And the managed care company would give you a denial and write back, treatment plan, go to AA. That's cheating. That's crap, because it says we don't want to pay. And it is not appropriate for managed care to recommend AA except as a supplement or a complement. And they don't really necessarily have to have an opinion on it at all, because it's not what they've been asked to authorize. It's something out of the insurance benefit. Here's the policy statement. It says, patients in need of treatment should be treated by professionals following the ACM criteria or other criteria. Self-help groups are not really self-help groups, but peer support groups should be recognized as valuable community resources for many people, not all. It doesn't click for everybody. And managed care companies should be aware that there's a difference, and self-help should not be substituted for professional treatment. It should be considered a complement. And that would be with an E, not complete. It's complement, not complement. Sorry for the typo. Okay. Now, again, I was the chair of the Diagnostic and Descriptive and Diagnostic Terminology Action Group of ASAM, which developed some of the definitions you've seen today: definition of abstinence, definition of sobriety, definition of recovery. But first, we developed the definition of addiction that was approved by the ACM board in 2011, at a short form and a long form. In the long form, we thought people might read it, and in fact, they did. And so we included some stuff that was beyond just definitional or descriptive of the condition. And we said things about recovery, and basically wanted to deliver the message that treatment works. So we said, as in other health conditions, doing what you can on your own, DIY, is great, but mutual support is also important. Peer support, such as that found in self-help activities, is beneficial in optimizing health status and functional outcomes. Again, these are always your goals: improved health status and better functional outcomes. Recovery from addiction is best achieved through a combination of self-management, mutual support, and professional care provided by trained and certified professionals. And that care can include talk therapy or meds. Another aspect of this is recovery coaches. Now, they've gotten more popular with the ED to recovery programs like we have in Wisconsin that you're going to learn about at that next Echo, because Wisconsin Voices for Recovery, which is where the Recovery Coach program is housed now, and where the ED to Recovery programs are housed now, is going to come talk, which is great stuff. So recovery coaches, they are not therapists. They don't do therapy. They have life experience that they share with someone. They share their life experience of addiction and recovery, and they are simply there to be the shoulder to lean on and to walk the journey of recovery with the individual, but not to do therapy. All their work, their coaching is action oriented, and it's behavioral, and it's on the present and what's going to come next. And it does not deal with the past, doesn't deal with trauma, doesn't deal with family of origin issues, doesn't deal with anything in the past. It's like the past is gone. We have zero control over the past. We're going to deal behaviorally with the present and set you up for the best possible future. So it's not therapy. There's no diagnosis, there's no treatment. And really, there shouldn't be funding, but things are starting to blend. They're not as purist as they were. There's the idea of getting recovery coaches covered by Medicaid, but it's just coaching. It's kind of interesting. And obviously, recovery coaches shouldn't just be volunteers. So recovery coaches now get training and certification, which is sort of quasi-professional, but they're not therapists. They're just coaching, being behavioral guides. So again, A is a supplement for treatment. It's not a substitute. It's for recovery people. It's offered by and for recovering people without the lead of a professional. Again, Smart Recovery has a lead, and if clinical professionals show up at Al-Anon or AA, they need to act like a human being, not like a professional. It promotes recovery, but it's not treatment. Now, TSF, on the other hand, is professional treatment. It's an evidence-based practice as determined by SAMHSA. It's a type of psychotherapy, and it was developed to be a part of Project Match. Project Match is almost a quarter century old. It was conceptualized with the hypothesis that we might be able to find some pre-treatment characteristics of patients that would make either MET or CBT or TSF more therapeutic for them. And so they had some hypotheses, and they did divide groups. They did matched comparisons, and they put people into one of 3 different therapies. The result of Project Match was that it was a failure in that they discerned no differences because everybody got better. People getting MET, CBT, and TSF all got better. So offer people professional help and don't try to split hairs over who gets what. And we also know through the tremendous work of Bruce Wampold here at UW and other psychotherapy researchers that the therapeutic relationship is more powerful in determining results than any modality. So whether you talk about rational emotive therapy, whether you talk about dialectic behavior therapy, whether you talk about psychoanalytic psychotherapy, which has horrible results, if you want to talk about whatever kind, MET, TSF, whatever, far more powerful than any of those intra-modality differences is the quality of the relationship as perceived by the patient. But at any rate, Project Match showed no differences, but everything works. But what is this TSF stuff? Again, to do research, all the therapy has to be identically done from one patient to another. So a manual tells the therapist how to do it. The therapists have extensive training in doing it. There's videotapes of the sessions to make sure there's fidelity to the model. And they developed a manual at University of Pennsylvania where Tom McClellan worked. Actually, Tom Woody and others worked on the TSF manual. Now, it's public domain, and you can even download it still. And it's a pretty thick sucker. It's well, it's thicker than my thumb. There you go. So what does this tell people to do? It tells you to be very behavioral, have people do journaling, and have people tabulate their behaviors. And so, you know, a lot of people say I use AA in my practice, and what that means is they tell patients, I really think you ought to go to meetings. That's it. Now, I'm not saying that's bad, but it's necessary, but by no means sufficient just to give advice to go to meetings. You need to follow up and see if they're really doing it. Some people in their practice will do things like write a prescription. Of course, this day and age, you would be using the EHR platform, but you would print out a prescription and you would say on it, exercise for 30 minutes 3 times a week, or take a walk for at least 2 miles 5 times a week, or limit your caloric content to whatever. And so doctors do this it's like drama, and I'm very dramatic in my therapy. I've always been, theatrical. So writing a prescription for a behavior change is certainly a modality that probably all of you in practice and some of you in training have heard of. But just telling people to go to meetings really isn't sufficient. TSF is far more than that. You find out what happened. Did you go? Did it work? What was good? What was bad? What can you do about minimizing the bad? What can you do about increasing the likelihood that you'll go? And so it's probative. So how many did you attend? What was your treatment goal for this week? Did you meet your goal? What's getting in the way of you meeting your goal? Attendance is the first component. The next component is you don't just warm up a chair, you actually open up your mouth. So when it gets around to you, and again, in AA, there's no crosstalk. It's not like a therapy group where the group gets really engaged and everybody kind of goes back and forth and may even give advice. In AA, one individual shares from their life experience, next shares from theirs. Another person may piggyback on the person and say, well, you talked about this. My experience with that is such and such. And then at the end, everybody says, thank you, and you move on to the next one. So it's a very interesting format, and everybody should attend AA because you can know what it is. If you're a professional in the field, you definitely should attend. And try to get into a closed meeting, not just an open meeting where it's a speaker meeting. But at any rate, did you pass or did you speak up? And a lot of people will go to 5 meetings a week and won't say a damn thing. You're not going to get that much out of it if you're not really participating. Next, beyond participating in the meeting, is getting a sponsor. Next, after getting a sponsor, work with your sponsor, meaning meet them for an individual once a week, or telephone or text maybe 5 times a week, what have you. So get a sponsor. Work the steps, 1, 2, 3, 4 to 12. There are step meetings at AA. You can look on the schedule to see where the step meetings are. And they talk about step 1 one week and step 2 the next week. And every 12 weeks they rotate to talking about what's in the steps. There are books written on the steps. I didn't put a picture of the Hazelden pamphlet, which is one example. There are pamphlets that teach people how to, what the steps are about, what they're intending to accomplish. And so thing is, are you doing anything beyond the meetings and talking and working with your sponsor and working on the steps? Are you doing chores around the clubhouse? Are you sweeping the floor? Are you raking the leaves? Are you shoveling the snow? Are you cleaning the coffee pot? Are you decalcifying the Keurig machine? Are you the treasurer? You volunteering to take the money that was in the hat that was passed and put it in the bank account and to use for various expenses? One of the traditions is no bureaucracy, but there is some, because there's sort of a thing like all the meetings in the town are part of what's called intergroups. Sometimes call it something different. They call it the central office. And then intergroups sometimes are aggregated at the state level, and then there's AA International in New York City. So there is a representative from each meeting to intergroup. Now, I don't think like at the Pittsburgh Recovery Serenity Club, I don't know if every group's GSR reports centrally to the Serenity Club. They might, but in most communities they report to intergroup for the whole community. It's an administrative job. And then also, do you go to retreats where people talk about certain recovery themes like powerlessness and arrogance and acceptance and all these different AA concepts? Do you go to conventions that happen once a year? Or and the other is, do you do social events like game night, like dances, like Halloween, New Year's parties, like camping trips? WICIPA, which is Wisconsin Young People in AA, which is a very interesting group. They do whitewater rafting on the Fox River up by Peshtigo. And for young people, that's really a very helpful thing. I mention these because they exist and they're important, but I mention also because research shows that the best results happen when people are not just doing the first 4 bullets, but are actually doing activities, the bullets 5 and 6. That may be a circular argument, a self-fulfilling prophecy, but it is true that people that take it to that level have the best results. And so, again, you want to follow the winners. So when you're doing TSF or doing any kind of therapy, you can integrate AA concepts into your therapy. You can talk about unmanageability when they say they can do it. You can talk about, we don't know what's happening here. Somebody needs to mute because it's driving Matt crazy that the system's not working. So when somebody said it's all about willpower, well, it's not. You need to let go of control. And a familiar metaphor that's used is, you got your hands tightly on the wheel of this bus. Where's that gotten you? Does that really work for you to be in control? Let go of some control. Let somebody else drive the bus. And then the other, of course, is hang out with winners. Do what winners do. And we always recommend that, and I recommend that to patients. And so an example that I like to give is Russell Wilson, who Madison football fans know when he came here as a graduate transfer in 2010 season. And when he won his first Super Bowl in his second year in the NFL, he was up on the big podium that they assembled at the 50-yard line after the game, and the confetti's falling, and the commissioner's there thanking the owner and presenting the trophy to the owner and blah, blah, blah. What's Russell Wilson doing? He's over there on the side talking to the Fox Sports guy, Terry Bradshaw, who was a quarterback who won 4 Super Bowls. What Russell Wilson did that day was to go to Terry Bradshaw and say, I just won my first Super Bowl and I'm 24 years old. You won 4 of them. How did you do it? This is a great way to be successful in life, is to hang out with winners and to do what winners do and read about what winners do and research what winners do and do what winners do. And those that go to AA have a better winning percentage. You want to talk with your patient about openness, rigorous honesty, and the toughest hurdle in the AA program is the 4th and 5th step, do a searching and fearless moral inventory. It is so difficult that most people that do AA do 1 step or 1, 2, 3, or maybe 1, 2, 3, 4. But 5 is after having done a fearless, which means not timid, not partial, but you just do it. And searching means it's not just what's on the surface, but you dig and you get in Pandora's box and you find out what the hell's in your mess, in your life mess. After you've written it all up, which is step 4, then you sit down with a human being, often your sponsor, sometimes a pastor, sometimes your therapist, somebody, and you recite it. You share it with another person. And that behavior makes results better. So what's expected of people who do go to professional help, like an IOP or residential program? Don't tell me AA sucks, it's not for me, without having your own experience with it. You will have an experience. It is an expectation of this program. And I think every program should have the expectation that you will try it. You can come back and tell me what it was like. And if you don't like the first group, try a different one. So you really, really, really lean on people to give it a try. And after 4 weeks, after trying 8 or 12 groups, if the entire experience still gives you nothing at all, well, that's fine. But give it a try, because you may be surprised. You may like it. And of course, we always tell patients, this is a classic AA line, keep going until you like it. How long should I attend AA? Until you like it. It's a great answer. It's expected that you'll take risks and open up, and you'll try new groups, and you won't necessarily have to have a first friend bring you. And that, again, you may not use a sponsor, but that's a part of the success. So try it out. When I worked at Rogers, we had a wonderful alumni association who agreed to be temporary sponsors when people were in residential treatment. When the person was discharged, they said, can I keep you as a permanent sponsor? No, because I have to be available to the next cohort. And so there was a group of 20 alumni that served as temporary sponsors, and it was really, really great. And so don't tell me that you don't like working with a sponsor until you've tried it. So again, experiential learning. Experience AA and experience the sponsor relationship. Because that relationship can really make a difference for you. Okay. When you ask people, are you attending and are you speaking, you will find a certain percentage with true social anxiety, and that can be reduced by a buddy, or even seeing a professional and getting a beta blocker or getting something else for anxiety. We generally don't give benzos to people with alcohol use disorder or other sedative use disorders, or probably ideal not to anybody. But something else for anxiety, such as an SSRI, that will be working nicely after 4 weeks. So if they have true social anxiety, they're not going to walk into the clubhouse very readily. But you learn this not by saying, I think you should go to AA, but using the techniques of TSF and probing and asking, don't tell me about your good intentions, tell me about your behaviors. Don't tell me I try. Cindy remembers the thing that we euphemistically called things people say. It was shared with me by a counselor who taught me a lot back in 1985 to 1989. And he used the same list and put it on the wall, and he called it the bullshit words. Some, maybe, I think, later. So how many meetings are you going to? Well, I'll try to go to 5. I didn't ask you what you're going to try. How many meetings are you going to attend? About 5. No, about's one of those bullshit words too. What are you committed to behaviorally? Okay, we got a contract. You've committed to go to 2 meetings this week. We'll shake hands on it. You're going to tell me what it was like, whether you spoke up or not, whether you felt like it was a good place, whether you felt like you belonged, whether you felt like it was creepy and you felt out of place, whether it was there were guys hitting on you, which can be a very tough thing in AA. You're going to tell me what it was like. Okay, got it? So the First Friends program of AA seems to have gone away. Some of you may have experience with it, but it was a concept where you could call a clubhouse and say, I'm just kind of scared to show up. Can somebody meet me at the clubhouse or meet me at Panera beforehand, and we can go into the meeting and I won't be walking in alone because it would just scare the pants off of me. I don't want to do this. Can you just be my buddy? And that's what First Friends are. But recovery coaches actually do the same kind of function now, is they'll take you to your first meeting or take you, to your first 10 meetings. In the manual, there is a check-in process, and this is the essence. People catalog, they record, they log, they journal their behaviors. They can do a CBT journal about their thoughts and their feelings and their urges and their cravings. And it's how many meetings have you been to in the last interval? How many sober days have you had cumulatively? How many days since your last use? And again, this can be since your last trip to the casino, if that's your disease. Are you having cravings? Are you getting close? Do we have to deal with that? Have you had any slips where you didn't have a full-blown relapse, but you had a slip? Are you reading the big book? Are you reading books on the 12 steps? Are you reading daily meditations? So are you doing other self-help reading? Are you making phone calls to people on the phone list? Are you in contact with your sponsor? Are you working the steps? And you ask these things. Again, this is probative. It's not taking anything on faith. Behaviorally, show me, show me, show me, like in Missouri. Demonstrate to me. Okay. And so a fascinating article is that for buprenorphine patients, NA does not add anything. And of course, there's other articles that say professional treatment doesn't add anything. So you got to have a balance of knowing what the literature shows. It's interesting that the TSF manual is, I think, a 12-week course, which obviously doesn't treat a chronic disease, but it's a structured thing for 12 weeks, and it can be done individually or in groups. And at the end, they make a big deal about the last session, the termination session. And at the last session, you ask them to reflect. What's been your experience over these 12 weeks with going to meetings? Has it changed? Did you get a sponsor? How was that for you? Did you get active in the clubhouse? Did you use your phone list? You meet with the patient on that last time, and if they've completed the first 5 steps, that's fabulous in 4 weeks. That would be great. Kind of unusual, actually. But tell them you got 7 steps to go. Tell them it's a marathon, not a sprint. Tell them it's a chronic disease that has to be managed over time. There's no room for complacency. You get overconfident, you get cocky, and you're in this honeymoon and you think that you got it licked. It'll bite you in the you-know-where. So the manual describes what to do in that last session, including saying, okay, what are your plans? I mean, with me, I was riding herd on you. Every single week we made a contract for how many meetings you're going to attend. Are you willing to do 90 and 90 now that we're done with this? You're willing to commit to 2 a week? Fine, we're going to shake on it. Best wishes to you. Come back if you ever need to see me again. This sort of thing. You're going to keep writing your journal. Remind people that it's available. And that's one of the great things about AA is if you go on a business trip, if you go on a vacation with your family, if you go to Mexico City or London or Seattle or Moscow, you can find a meeting. And it's free everywhere. It's ubiquitous. And again, I love smart recovery, but it hasn't won in the marketplace of ideas. There's not as many meetings, not as available. I mean, it's great for people to go there. I support it all the way, but it just hasn't caught on in 25 years like AA has in 85. Okay, let's see what else. Does this improve outcomes? This article says it does for methadone patients. When you're looking at the literature, you want to look for these authors. These are the people who do the best research. John Kelly is in his 50s now at Harvard. He was writing like a banshee in his 30s. He's really probably the best respected and most prolific author now. Rudy Moose is probably retired now. I think he's still alive. But Leanne is wonderful, gave a tremendous Smithers lecture back in 07 that I attended. So a lot of these people in the Bay Area, you see, Keith Humphreys was in the drug czar's office and went back to Stanford. Mark Gallander's in Manhattan. Again, he's chair of the ASAM, and you don't have to be a physician to be an ASAM. You can be an associate member now, but he's the 12-step recovery interest group. Now, the rest of this of your handouts, which you've got electronically, are just excerpts from different articles. Here's by Humphreys and Kelly, and here's one by somebody else, Monaco. Here's one by Harvey, and it really talks about results. So the literature is available to you. You have a bibliography. You have these little clips. And then what can you do in your daily practice? You can advise people on the benefits of AA or NA. You have resources to share. Having a list from the internet you printed out is good to give to them. It says where meetings are on each day. It's nice to have a list of people from your practice who you can call and say, would you be a first friend? I got a new one for you. And almost always, somebody that's been in recovery, 6 months, especially 12 months, they're more than happy to help as part of step 12 for them. And so, I mean, my whole practice, I did this. I would have a list of people that I had treated, and when I had somebody new, I would know I could call them and say, may I have your permission to give your phone number to this patient in my office? And that avoids having a signed release for the patient to give their phone number to your former patient. So I give the number and I have my patient give them a call. So it's not just telling people to go to meetings. You can all, and so, and if you're a health professional, you should go to meetings yourself and see what they're like. So you can email me, you can call me. That's been my way. And I think I'll stay that way during my retirement. Anybody that needs me for a question on this, follow up, something you disagree with. We can take 1 or 2 questions maybe in the chat, but I know people scatter at the top of the hour because they have other places to get to. But that's what we did, and thank you very, very, very much for your attention.